Today's platform is WebEx Events, and to interact with you today, there is a Q&A section enabled to the right of your screen. So don't hesitate to ask for assistance there or to pose any questions that you have throughout the session to our speakers. Unfortunately, there are no closed captions on this platform for the moment, working on that, but the slides will be available for you in an accessible format to take away with you after the session. So if you would like to take away the information that's shared and the slides, we'll be able to provide them to you after today's session. For those who are new to the Commons, welcome. This is our space that's really dedicated to informal learning and knowledge sharing on issues of both professional development at the UN, as well as issues of multilateralism, which is really our core work at the UN. And we principally serve diplomats, UN staff and interns across UN Geneva. And now that we're online, people are joining us from around the world as well. Today's session is really diving deep into the latest research on mental health and COVID-19. The session, as you can see on the screen, is called Perspectives from HUG, the impact of COVID-19 on mental health, in collaboration with, of course, HUG, the University Hospitals in Geneva. Here at the Commons, we've been looking at the connection between mental health and the pandemic since April last year, actually, since we really, were involved in moving towards different ways of working and living because of the pandemic. And we've been looking at sessions with regard to keeping a healthy mind, how to manage anxiety and support anxiety, looking at also resilience and cultivating adaptability and mindfulness sessions, all in collaboration with the Staff Counsellor's Office here at Geneva. And so we're really glad today to be able to take that learning a step forward and work with HUG on this important topic. And I'm going to introduce our special speakers to you very soon. There's a lot of information in the media on COVID-19, as well as a lot of growing scientific research as we understand more about the virus and the pandemic. And so as you see on the screen now, we have some learning objectives for the session because we only have an hour. So we're going to look at the impact of COVID-19 on mental health in the general population, the organization of mental health services during the pandemic, the neurologic and psychiatric sequelae of acute COVID-19, and also how to deal with uncertainty, which is one of the main stresses that's related to the pandemic, as we are all experiencing now. So to take you through this, I'm very glad now to introduce you to our speakers. Our key guest speaker today is Dr. Stefan Kaiser. He's the head of department in the Department of Psychiatry at HUG. So he'll be really leading us through our learning objectives that we just saw on the previous slide. But also joining us for some opening words, we have, in order of presentations today, some opening words from Natalia Mironenko. She's the Chief of the Human Resources Management Section, or HRMS, in the Division of Administration here at UN Geneva. She'll be sharing a bit about what's been happening in terms of UNOG's work in this area, as well as the collaboration between HUG and UN Geneva. Also joining us is Karine Martinez. She's the Executive Affairs Deputy at HUG, and she'll also share a little bit more about the role of UG in this topic. Finally, we have with us Mary Bridget Leahy. Many of you perhaps already know her. She's the Staff Counsellor here at UN Geneva, and she'll share more about what is available to you in terms of services, in terms of counselling here at UN Geneva, and also the work that's been happening already. So thank you so much to all the speakers for being here and taking this time to share with us. Today's session is in English. However, we welcome your questions in English or in French. We're very happy to take them all. So whichever language is more comfortable for you. That's enough from me. Let's begin with Natalia. Over to you. Thanks, Natalia.
Good afternoon, colleagues. What I would like to tell you is what was our response to COVID pandemics and how we found out that the mental health was crucial. So from the beginning of pandemic, UNOG Human Resources team, which comprises also Staff Counsellor's Office and which comprises also medical services, has been working actively as part of COVID response team, supporting staff with various administrative issues, providing medical guidance, close contact tracing, following COVID positive staff through our medical services section, and providing psychosocial support by the Staff Counsellor's Office. It became very obvious for us early on in the first lockdown that staff mental health was going to be of great importance in the context of all the challenges we were facing, and with indications that many colleagues were experiencing a lot of stress and anxiety. Just remember how we were experiencing big change in working environment, less than ideal office setups, and for many an increase in workloads. We worried about our health situation, disruption to our daily lives, restrictions on our freedoms, missing social interactions. We had extra stress from looking after our children, both during working hours and after, and doing homeschooling. As international civil servants, many of us were far away from our home countries and families, some of whom may have been in even more difficult situations that we were facing in Switzerland. Some of us, of course, also suffered illness from COVID-19 or lost dear ones. In order to cope better with the pandemic, we have encouraged staff to support one another, which have been crucial throughout this period. It was heartening to see so many of you stepping up and offering to lend a helping hand when you could see colleagues who needed the support. A big thank you to all who provided such support. In June last year, we had an idea to have to take a snapshot and send a staff survey to see how people felt about this forced telecommuting experiences during the first lockdown. And the findings showed that there was certainly presence of a lot of anxiety among staff. However, we were pleased at that time to see that overall staff had fared better than we perhaps would have expected. In hindsight, we believed that this could have been linked to the timing of the survey in June last year, which was a period of optimism and measures were easing. Many of us believed we were coming out of the situation. What was positive was that many of you, 77% of respondents, said that they had felt supported by their management. And we also want to give a big thanks, big applause to the managers who supported their staff. And it was very important. And managers supported the staff's well-being in this way. When the second semi-lockdown period started in the fall, we felt that a mental health of our staff was once again preoccupying. It is therefore very timely and also a privilege for us to be able to introduce the session today and to welcome the representatives of HUC and especially Department of Psychiatry to share their research on the impact of pandemic on mental health. And I have to say that our close collaboration with HUC started back in 2012 on various medical issues. And it is my pleasure to introduce the next speaker, Karine Martinez, Deputy External Relations of HUC. Over to you, Karine.
Thank you very much, Natalia. First of all, I'd like to take this opportunity to thank you, Mrs. Mironenko, as well as Dr. Achar and all his team for your continuous support and continuous interest, which make the UNOG-HUG collaboration possible and fruitful. Collaboration with international organizations and in particular with UNOG is very important for HUG, as it is the expression of the International Geneva. Already, we have together implemented projects in different medical domains, such as emergency medicine, travel medicine, psychiatry. As well, we have set up emergency protocols. We are now sharing experiences and already lessons learned from this COVID crisis. And as you know, the challenge for a university hospital like HUG is to build upon this experience and to be able to manage further crises, if any. We are keen to participate today actively in this first edition of a UNOC conference series, which I'm sure is meant to be set in a long-term perspective. Thank you very much. Mary, it's your turn to take the floor, I believe.
Thank you very much, Corinne. Thank you very much, everyone, for joining us today. And so my name is Mary Leahy, and I'm the staff counsellor with UNOG. And I would like to just explain a little bit about the role of what we do and how we can support you. So our main purpose is to provide individual support, but also support to teams, and also to look at the organization as a whole and how we can notice trends, maybe see what's going on. And the pandemic of COVID-19 is a perfect example of this. So, for example, we work closely with our colleagues in HRMS and with medical services and with the Staff Coordinating Council to look at how we can best support staff during these times of change, where many people who had never telecommuted before had to start. And then, like Natalia mentioned earlier, many people had to struggle with their home life and also trying to get their work done, trying to find the balance. So basically, we like to think about how do we promote well-being in the workplace. And by doing this, we mean how can we look at prevention of ill health, how can we identify and then find resolutions to problems which can have an impact on the staff's well-being and mental health. And by staff, we also mean interns and consultants. Everybody is welcome to come with us or to see us. And also it's about not just problems maybe in the workplace or stress from work, but also things that are going on in your personal life. Because of course, we know this can have an impact on your working life and you as a whole person. So we look at the work-life balance where possible. Sometimes there's periods where you maybe have to work overtime or weekends, but then it's important to try to take some time to recover. We encourage you to take your annual leave and to share with your team if you're struggling or if you need help. And for example, in HRMS, they have a very good way of doing huddles where you talk with the team either daily or several times a week to look at what each person's priorities are and how can other staff members support someone maybe who's not doing so well. So what we do here is we provide it's confidential and a respectful environment for staff members and it's safe. We also work with external providers such as psychiatrists, psychologists, and psychotherapists and counselors. And that's for maybe some staff who maybe need a little bit more help. Perhaps you might be going through a bad time in your life where you're feeling more anxious than normal, or you might have problems sleeping. So then we always recommend that you work with your doctor as well to make sure that everything is checked out, and also your your nutrition levels are good, your blood is good, because it all comes together to help the mental health and the physical health. And of course, we work closely with our colleagues in the medical service at UNOG and also with our colleagues at HUG. So another big part of the role is that we work in collaboration with the Knowledge and Learning Commons with Natalie and her team, and also with our colleagues at the Centre for Learning and Multilingualism. And these days we provide training through the virtual platform, through MS Teams, WebEx today, and hopefully in the future we'll also go back to doing face-to-face trainings. So we look at in these workshops and webinars at well-being, at maybe mental health things that are coming up. For example, we looked recently at emotional intelligence and how we can get to know ourselves better, so then we can actually be more comfortable in the workplace. And by looking at our behavior, we can maybe have a more positive impact on our teams. Or if there's conflict in the team, we look at ways of how can we resolve some of these conflicts. And then, of course, we actively promote and advocate for the implementation of the mental health strategy, which was introduced in 2018, and it's a 5-year plan. And we do this in collaboration with our colleagues in New York headquarters and with the network of staff counselors around the world. But of course, with managers, with team members, it's very important. And then, as Natalie also mentioned, we offer mindfulness meditations in English and in French. And for anyone who needs more information, please just reach out to us at staffcounselor@un.org, and we'll be very happy to support you. And now I'll just hand back to Natalie. Thank you.
Thank you so much, Mary, Karine, and Natalia. Without further ado, let's hear more from Dr. Kaiser. Thanks so much, Dr. Kaiser, over to you.
Yeah, thank you very much for your invitation. I appreciate it a lot. It's a pleasure for me to be here and to share some thoughts with you about COVID and mental health. I feel I have to share my slides first, so excuse me for a second. So, no, this doesn't work. So now you should be able to see my slides. Okay.
Perfect, yes, thanks.
Yeah, and I'm not really an expert on the topic, but I don't think there are a lot of experts in the world now, because it's a new topic. And you've probably read it in the press, seen it in the media, that many people talk about a wave of problems of mental health that is coming, a tsunami of mental health problems. There are others who are a bit more cautious about this, and say it's quite a heterogeneous phenomenon. So there's a ongoing discussion, and we don't really know exactly about the wave, and that has several reasons. We know that there are more problems with mental health, and I'll try to share some knowledge with you today. But we have a huge problem, because what we know that there's a wave, a tsunami of articles on mental health and COVID. And so this colleagues in Bern who are doing a huge analysis with several hundred team members, and they have identified about 40,000 articles on COVID and mental health that are probably potentially relevant. And so you can very well see, for me personally, it's impossible to always give you the right answer. So I'm trying my best, but it's impossible at the moment to have really a comprehensive overview of the literature. But I think nevertheless, we'll be able to identify some key issues, and the other part is to share some experiences from Geneva with you. So this is the cause of the epidemic in the canton of Geneva. These are the data from the health, from the cantonal health services. So you see the first wave on the left side in March, April last year, and what was already mentioned, the kind of the more calm period in the summer, and then a huge second wave in Geneva. And Geneva was for several weeks the hotspot in Europe with the highest rate of infections. And then afterwards it went down, and actually it's from, I think, 1 or 2 weeks ago, so it looks even better now. The problem with the mental health data is that most of the data concern the time of the first wave of the pandemic and the time period in the summer. So we don't really have a lot of current data, which tells us what's going on with the mental health of people in the general population and specific populations today. You've already seen the overview, the goals of the presentation, and we'll start off with COVID and mental health in the general population. So to make it brief, there are 3 types of symptoms that are commonly observed in general population studies. Of course, this is always a bit driven by what you're looking for, because you can only find what you're searching. But it's quite consistent, has been quite consistently shown that depressive symptoms and anxiety symptoms are much more prevalent than before the pandemic. And that's what we generally see. And this is more or less in the whole population. We find really across the general population. We will be looking at the details a bit later on. The symptoms of post-traumatic stress, symptoms which kind of remembering certain aspects, certain situations, flashbacks and things like that, those are more frequent in people who actually had a trauma. So either they had the infections themselves, they had the fear of dying, who lost a relative, or also kind of frontline healthcare workers who are in very difficult situations to take care of a lot of patients, and also saw a lot of patients dying in these conditions. So that's more specific for certain populations. There are other problems: suicidal ideation linked to depressive symptoms, sleep problems also often linked to depressive symptoms. And there's also discussion about increased substance abuse, but that is quite heterogeneous. There's a recent study in Geneva which didn't really show a consistently elevated substance abuse, but there are also other data. The problem with all these data is that, first of all, we detect symptoms and not diagnosis, because it's mostly questionnaires that are often done online. So it doesn't allow you to diagnose depression. You can identify depressive symptoms, but that doesn't mean that there's really a major depressive episode. And then the other problem is the sampling strategy. So that mostly these are convenient samples. So you just have the data on the people who are accident or because they want to participate in a survey, but we don't really know whether that's representative for the general population. So that's another problem. So this makes it very difficult to really conclude from this data what we should do in terms of mental health services. So we have some alerting signals, but we don't really know exactly in the general populations how symptoms and in particular diagnosis are distributed and what need for care is actually there. So we can conclude from this there's probably more need for care, but to quantify it is extremely difficult. And there are some risk factors, and there's some populations who are at risk for mental health problems, and was quite consistently been shown across all countries, in fact, is that younger age is a risk factor. So that adolescents and young adults are the age group most at risk. And what seems a bit contradictory, there's also the real or perceived risk of a COVID infection. And that's a bit strange, because younger people, they're less at risk from having a severe consequence of the infection, but then it's sometimes perceived risk that also plays a role. And we also have to think about young people who actually have a comorbid somatic disorder, who are at higher risk. And so young people with comorbidities are probably grouped specifically at risk. Female gender is the risk factor. That's a bit difficult to assess, because for depression and anxiety symptoms, generally female gender is a risk factor. So it's difficult to say whether this is specific for COVID or not. And then you have pre-existing mental illness, but generally also the illnesses we already talked about, depression, anxiety, and others. There's one excellent study, a Swiss study, which has actually looked at first and second wave data. It's a study by the colleagues in Basel, and De Kevin et al. You find it, if you type Swiss Corona stress study in Google, you find it right away, and they already have the results online. And so what they saw during the second wave in November, at the peak of the Swiss epidemic, you see on the left side, and in pink or in red, those are the people who are above a certain cutoff in terms of depressive symptoms. So they say it's moderately or severe depressive symptoms. That's not a diagnosis, but it shows the presence of quite important symptoms. And what you see is that in the population of young people between 14 and 24 years of age, you have more than 40% of the people who have at least moderately severe depressive symptoms. So that's quite impressive. And it actually goes down with age. So this is not necessarily representative, kind of old people who participate in an online survey, not sure that these are those that are most at risk for depression, but still, these are impressive numbers. And the other graphic, which is interesting for us, what they tried to do is they looked at the relation between the incidence in the canton in November and the percentage of people with depressive symptoms. And as Geneva is kind of was the canton with the highest incidence, you will also see it's in the right upper corner. It's also the canton with the most people with moderately severe depressive symptoms. And there's quite a nice linear correlation between incidence and frequency of the depressive symptoms. So in other words, you could say that the young people in Geneva are those that suffered most during the COVID pandemic in terms of their mental health. And that's actually also something that we see in clinical practice. And I'll come back to that in a minute. And there are some other risk factors that we know that they're not that specific to COVID. So living alone, feeling lonely is a risk factor for mental health problems. And socioeconomic status is also a risk factor that we know from other studies even before the pandemic. There's one study from the US which I found quite shocking, because there they found that actually food insecurity is even worse than just losing your job. And that in a developed country that quite a few people have actually don't know how to put food on the table, and that this is very much linked to mental health problems. There are also protective factors. So you have social contacts. And of course, this type of social contact was very difficult during the pandemic. But people who had this kind of social contact before the pandemic fared actually better during the pandemic. And there's a big question of how you can preserve your social contact. But if you don't have any before, it's difficult to preserve something. Exercise is a protective factor that has been shown quite consistently. And there are also 2 studies showing that pet ownership, that's actually our cat, kind of relaxing during the pandemic, is also a protective factor. So what do we do with this? And I think, of course, you have to strengthen the protective factor, and the strengthening of the community. I think that's kind of a very basic thing for mental health, and not only in times of the pandemic. So how can we manage that people actually talk to each other, that people help each other? And this can be the neighbors, that can be the community at work, so community in quite a large sense. But I think that is something that we've learned even more than before, that is very essential, and to preserve the community in some way during the pandemic. So what I find quite interesting, our patients were really upset that we stopped group therapy, because the group of patients was a community for them, and they were really angry. I was very surprised by this kind of revolution we saw. Protective activities like exercise, I think that's quite clear. For mental health services, I think we don't have to think always in terms of kind of major interventions, pharmacotherapy, psychotherapy. I think it's very basic. What we can start off is to really raise awareness, destigmatize mental health problems, to have kind of first persons of contact, the school psychologist, the GP, but also the staff counselor at the UN would be a first person of contact. These people are really aware of the problem and are quite easy to reach. Then there are self-help interventions for depression, anxiety, more symptoms than disorders, that can be quite useful. And it's not necessary always to have a major intervention for everybody who has some mental health symptom. Then turning to the organization of mental health services. So there's a tsunami coming or not? So what did that mean for us? And the first question was, even before all that, was in March 22, when the Swiss federal government decided that all non-urgent care should be stopped. And this put us in a quite a tough position, because of course we can't close the hospital. That was quite clear. But what we do with psychiatric outpatient services, do we close everything down, only provide emergency care and teleconsultation? And after a bit of discussion, it became quite clear that we thought we couldn't do that for several reasons. So the people that are seeking care with us are a very vulnerable population, often with severe mental illness. And we thought that we really have to guarantee the access to care. And what's also quite clear in this population, if you stop everything that is non-urgent in the strict sense, then you will have a lot of need for urgent care very soon afterwards, also with an increase of hospitalizations. And a psychiatric inpatient unit, that's probably the most difficult place to manage, because you have a lot of people in a relatively confined environment, people who don't necessarily understand the sanitary measures. So we thought, okay, we need to keep outpatient services running with some adaptation, with all the security measures, with some teleconsultation. But the decision was we keep everything open to avoid kind of consequences of failing access to care, like psychotic decompensation, suicide attempts, but also to avoid hospitalization. So it was a tough decision, but at the end of the day, it worked quite well, and patients were able to respect quite well the sanitary measures which allowed us to keep this approach. And what we actually saw, that there was a reduction in emergency room visits and hospitalizations during the first wave of the pandemic, and that's seen everywhere, at least in Europe, but also in the United States. So people were, I think, afraid to come to the hospital. But what we saw then, that there was a rebound after the lockdown, so that people didn't seek care, even though it might have been better to seek care, and then they came after the lockdown period. Another approach, and I've already mentioned this, is really to use telepsychiatry, telemental health. There are some data from before the pandemic concerning telephone and video consultations. And of course, this has had a lot of advantages during the pandemic. It was a means of assuring continuity of care during the lockdown. There are some studies also suggesting that people actually miss less appointments with teleconsultation. I'm not sure that that's really true. And sometimes it facilitates meeting with everybody in the network, the family, with a social worker, and other people. So there are quite some advantages, and we had some good experiences, but it worked for some patients, but not for others. And there's several reasons for it, and there's some research also on this. And there's some barriers. First of all, there are technical issues. I mean, I think everybody in the audience has probably experienced some problem with some video conferencing, and this can also happen when you actually see the patient. And some patients actually don't have a smartphone and don't have a laptop, so it's a risk of excluding vulnerable groups. Another problem is safety and confidentiality, and that today I think has become less a question of technology, but for our patients more to have a private space for having a conversation with their doctor, and that many patients don't really have that. The other problem is certain groups with hearing difficulties, cognitive problems, language barriers. That also becomes quite difficult. There's also debate about the therapeutic relationship. I think there the research results are a bit ambiguous. And the last point I also mentioned before is that some of the patients was very clear that actually for several months their only contact with other human beings basically was the doctor, the nurse at the outpatient clinic, and also the other patients. Even it was a bit contradictory because we tried to reduce contact, but on the same time, there are many patients who told us, but I mean, I come here and that's what I want. And we also saw during the second wave that patients really did want much less telepsychiatry and much more consultations in presence. So of course it's quite difficult. You always have to find a compromise to ensure safety and at the same time provide some sense of community for the patient. One of my leading physicians, he said, we don't just treat psychiatric disorders, we also treat loneliness. And I think there's some truth to that. So the current situation, just to talk about that briefly, is we have the population with mental health problems, but they don't arrive at HUG directly. So first of all, we still see the general practitioner, a private psychiatrist, and there we have consistent feedback that the mental health problems have clearly increased. The GPs tell us that, the private psychiatrists tell us that. And then afterwards, they will be addressed to our outpatient clinic and maybe to the hospitals. And what we see is actually quite a high activity. It's not really kind of a tsunami at the moment, but what we see is that there's a massively increased demand for crisis intervention for young people who don't do well, really in the age range I mentioned before. So there's a pretty we have about 5 times as many patients as usual. So it's really a massive increase in this group of patients. So what can we do? I think crisis intervention that is flexible and accessible is very important. And it doesn't really mean that there always need for 1 year of treatment or psychotherapy. I think for telepsychiatry, we have to work a bit on it to make it mentally more accessible for patients and professionals. Another aspect I didn't mention before is home treatment and community care, to really go towards the patient where he lives or she lives. I think that's a very important point because that's also not very risky in terms of transmission. And we know from many studies on psychiatric services that's actually quite useful even outside of the pandemic. I'm staying quite optimistic, I have to say, even though I told you a lot of data about mental health problems. I think the young people, this is a crisis situation. A crisis by definition is temporary. And I don't believe that this will necessarily create a new chronic population. I think if you take care of these people, if the situation gets better, which we all hope, then these crises will be temporary. And the other aspect is that we actually, in our patients with really severe mental illness, we observed much more resilience than we originally thought. We thought that there would be many who would need hospitalization, who would do a lot worse, but actually they were quite strong during this crisis and they did reasonably well with all the difficulties associated with it. So that was quite a positive surprise, and that's also documented to some extent in the international literature. The third topic I wanted to address with you will be shorter. It's much more medical, if you want. These are the consequences on COVID-19 on the brain and on, after an acute infection. And what do we observe after an acute COVID-19 infection? We observe the same symptoms as in the general population, but with even higher frequency. And that's not only symptoms. So we also have the data that actually depressive disorder and anxiety disorder are more frequent after COVID-19 infection than you would expect, and more frequent than with another respiratory tract infection, for example, influenza. So there seems to be something which is more problematic with a COVID-19 infection than with other similar kinds of infection, respiratory or other. There's the problem of fatigue, which is a major problem with long COVID syndromes and sleep problems as well. Psychosis also seems to be more frequent, the first diagnosis of a psychotic episode after COVID-19. It's less frequent than depression and anxiety, of course. And I've also mentioned post-traumatic stress symptoms before. And there you also have patients with post-traumatic stress disorder who really fulfill diagnostic criteria. Neurology, what we know, it's more frequent is stroke. So either bleeding or lack of oxygenation in the brain, which with all the neurologic and psychiatric consequences that this can have. What is very frequent is some form of cognitive impairment, also with these COVID long syndromes, where with a specific effect on attention and executive function. Executive functions are plannings of actions and how to coordinate complex behaviors. So the people who have a COVID long often are fatigued and they have problems with attention and executive function. In most of these patients, this gets better over time. These are not necessarily symptoms that stay. I mean, we don't really have very much longitudinal data now, but it seems that after 6 months or so, most of the patients actually improve. Another point which is a bit disturbing is that there's actually evidence that in older people who have an acute COVID-19 infection, new diagnosis of dementia is more frequent in the 6 months after COVID-19 infection. So we don't really know if we just pay more attention to these people or if some already ongoing process is accelerated, but it shows that the effects of COVID-19 on the brain are not harmless. And of course, all this, what I've mentioned, is also related to the severity of the infection to some degree. And I think there was one question, why is this the case? Why does COVID act on the brain? And of course, one important factor for psychiatric disorders is the psychological stress related to the illness. So, I mean, respiratory distress is really, it's a very anxiety-causing symptom. Of course, you can also be afraid of infecting somebody else. If you have a relative with risk factors, of course, it's stressful to have the COVID-19 infection. So this is certainly a major factor for the psychiatric side of it. There's also some evidence that there may be a direct viral invasion of the brain, that the virus actually moves into neurons. We know that the virus attacks the olfactory bulb, so this problem of smelling, that this is changed after COVID infection, it's very well known. It's one of the major symptoms. And this is actually very close to the brain. So it seems quite logical that this also goes into the brain. And there are also some research data showing that this actually might be happening. The degree is quite unclear at the moment. And then we have systemic effects of the infection. So here the infection is marked in the lung. We know that the virus actually attacks a lot of organs. But you have a kind of a very strong inflammatory response to the virus. And this is also why we treat patients in intensive care with anti-inflammatory drugs at the end of the day. And this is also very likely to have an effect on neurologic and psychiatric disorders, because we know today that many psychiatric disorders actually associate with a hyperinflammatory state. So meaning that, for example, in depression, there's an important subgroup of patients who have kind of a chronic inflammatory state. So there's inflammation going on in the body all the time, and this is linked to depressive symptoms. So we don't really know exactly what importance each of these factors have, but there are really these three ways. There's more the psychological way, directly the virus attacking the brain, and more systemic effects of an acute infection. And with this, I want to turn to the last topic. I will, of course, respond to all the questions afterwards. And this is, of course, I mean, there are a lot of factors, psychological factors, posing difficulties for us at the moment. And I think in the first wave, there was a lot of fear, and really people were extremely fearful of what might happen because we didn't really know, but we didn't really know, and we don't really know. I think that's a major factor that is creating problem today, because humans are fundamentally uncertainty averse. They don't like uncertainty, and they use means for reducing uncertainty. And of course, in this pandemic, there was or is uncertainty about almost everything. At the beginning, we didn't know how dangerous the virus was. We didn't know what the effective protection measures were, mask, no mask, what's most, we didn't know. We don't know, and we didn't know how the pandemic will evolve, what are the economic consequences of the pandemic. There was uncertainty about the vaccination, when it would be available, the side effects. So I think that there rarely was a time over the last years where there was more uncertainty about so many things. And I think this is really, at the moment, one of the major driving factors that creates mental health problems. And of course, there are several strategies of how to deal with it. I mean, some people just ignore what happens and just try to have as little as information as possible. It's probably not a very useful strategy. Others seek as much information as possible. That might be a good strategy, but it's a lot of work. And it's very difficult to find good information. So and it's quite stressful to seek information all the time. Of course, you could follow conspiracy theories. It's quite cost effective because once you are in the theory, all the questions are answered for. So that's not a problem anymore. It's probably not the best approach either. You can trust credible institutions. It's quite difficult, in particular when there's some contradictory messages. So there's really not an easy way of how you deal with this. And I think, as always, it's probably a compromise between seeking information and trusting people. That is probably the most efficient way. But I don't really have an answer for that. I think there are some strategies that we should stick to, and we are trying to stick to in our communication. I think clear and consistent communication is absolutely key. But of course, it's difficult because sometimes and oftentimes we don't know. And during the last 1.5 years, I often experienced a situation where I was supposed to tell something to collaborators and I just didn't know. And I think what is very important is to be honest about the uncertainty you have yourself as a communicator, because there's not only uncertainty, but there's also uncertainty about the degree of uncertainty. And this is even worse. When you don't know what the degree of uncertainty is, then you're even more stressed out. So if you at least can say, okay, this I know, this I don't know, this I know with 50% certainty, this I know with 80% certainty. Of course, these are not exact numbers, but I think that's already quite helpful for most people to be honest in the communication, clear, but also say what your own uncertainty is. I think that that at least reduces one aspect of uncertainty. And so with this, I come to the end. This was kind of a big tour of many different questions regarding mental health, and I'm looking forward to the discussion.
Thank you very much, Dr. Kaiser. This was really, really interesting, and especially some of the findings you gave us about the science and the impact on neurology and psychology. That was completely new for me, and I think for many people. So thank you so much. It was really insightful, and I think also it was a good reminder that to be kind to one another. We never know what might be happening in someone's life. So we do have a few questions coming in the chat, but we do encourage anyone who has any questions for Dr. Kaiser or any of our speakers to please put it in the Q&A section if you have some. But to begin, we have a question from Tina. Thank you, Tina. She's asking about the reference you made at the beginning about the fact that there perhaps is more risk for females to have mental health issues or symptoms. Is there any reason for that you could share? Could this be linked perhaps to maybe a more detection of symptoms in men, or maybe different types of communication? Is there anything you can share?
That's actually an excellent question. And I think to some extent, it's true that men tend to declare less depressive symptoms and anxiety symptoms than females, also because they don't want to, they want to be strong, and the symptoms are sometimes not exactly the same. For example, depressed men get much more easier kind of an irritated, sometimes even an aggressive state than women, and so you wouldn't probably identify this as depression right away. And there was an excellent article in the American Journal of Psychiatry some years ago. The title was "Real Men, Real Depression," with the idea that this was under-detected. At the same time, I think generally, even if you do well with the detection, you do the maximum, I think generally female persons are a bit at the higher risk for anxiety and depressive disorder than male persons. I think that's taking into account the certain bias still true. There are other psychiatric disorders where that's not the case, where actually for certain psychotic disorders you have a higher frequency in males. So it's not that all general health problems are more frequent in females. It's really the most prominent, the focus of the studies conducted on anxiety and depression. There, it's more prevalent in females.
Okay, interesting. Thank you. Looking then at different populations, you did mention there was some interesting findings that more young people are impacted by COVID, especially in the second wave, and young people in Geneva as well. Is there anything you can share with us about how we can support young people more in our daily lives, whether it's with our families or other young people that we know?
Yeah, I think actually young people had to quite some extent support from their families. I think that's certainly a protective factor. And in some cases, it was even when there was little contact between young people and their family before, then there was kind of a certain reunion. And in many cases, this worked quite well. But I think there are two issues. It's kind of the future, the uncertainty about the future, which is a problem. And I think they are really to work with them on their perspectives for the future in terms of formation and everything. I think that's an important aspect. And I think it's important that they have contact with their peers, but I think there are many of them also quite resilient, have found ways of staying in contact with peers. But those who hadn't really the contact before, for those it's quite difficult. So I think we should think about how to increase a peer community. I've talked about the community here before. for young people. I think that's an important aspect. I think these are the most important thing. And then actually when they are in crisis, that they have an easy access to non-stigmatizing crisis intervention. I think these are probably the most important things.
Okay, great. Perhaps Mary, you have something to share also on this topic about supporting young people. Maybe this is something you've experienced too in your practice.
Yes, thank you very much, Natalie, and thank you very much, Dr. Kaiser. I think, yes, often we have staff members coming and they ask about their children and maybe share some things that are going on at home. And always what I find is if the parents are doing well or the caregivers, then the child will feel supported or the young adolescent will feel supported. So it's also really important to remember to take care of yourself too, also while you're looking after your teenagers. And I think one important point that came up there for with Dr. Kaiser is you mentioned how people get sick, but they are getting better. And even a lot of people come to us and they say they have, fatigue after the COVID. It's hard to concentrate, but it is good news to know that it's people are actually getting better. And I would say as well, a lot of people are scared to even come to see the staff counselor in the first place or go to their doctor. But it's very important to know that there are specialists out there who are very caring and can really help, and you can get better. It's just we're still going through COVID now, but times will come again. Thanks, Natalie.
Thanks, Mary.
Maybe just adding to this, there was one question about fatigue, and it's both, it's cognitive impairments and fatigue that in most people improve over time. Not in all, but in most people improve over time with the data that we're having now, which is limited. But I think there's reason to be optimistic.
Okay, so a good lesson for us, yes, time. This brings us to our next question. It actually, that's about coming back to normalcy, which we have seen, some especially announcements in Switzerland that things are starting to open again, we can have more people in groups, etc. So what are your tips that we can take away on how to kind of support ourselves when normalcy is coming back? And there might be also a bit of social anxiety about things, returning. You can see it on the roads already, I suppose. Over to you, Dr. Kaiser.
Yeah, that's actually a good question. I don't really have an answer for that, unfortunately. I think generally what you observe, there are people who kind of want to return back to normal as fast as possible and do big party, but I also observe that, and I observe that in myself, that I'm not doing all the things that we are allowed to do at the moment. And probably, it's also important to take some time and not to to feel obliged to that everything returns back to normal, that we're doing exactly the same things now right away that we've done before. I think probably a bit, I would counsel some realistic expectations. This will take time. This is already has had a lot of impact on all of us, and if we won't, in a couple of weeks, we won't return to normal. It's not a realistic expectation.
Yeah. Mary, is there something you'd like to share on this?
Yes, I think that's a good point from Dr. Kaiser, actually, to still be careful, because we still don't know. For example, many of us have now been vaccinated twice, but we still don't know. So it's still important to wear your mask and to consider other people. And also I think self-care is very important as well. Many people told me they enjoyed being home at first. They were introverted people who were quite grateful that they didn't have to bother going out or go to all these invitations all the time. But then I think after 6 months, people got fed up of being home. But maybe I would say pace yourself, go to a restaurant maybe where you feel safe, you can sit outside, and still keep washing your hands and taking care of yourself. That's important because we're still in the pandemic. Thanks, Natalie.
Thank you, Mary. There's a question coming in from Marielle Garcia. Thank you. Are there any projects at the canton level or the federation level to conduct studies on the impact of COVID-19 on mental health? Perhaps Dr. Kaiser, or maybe even Karine, you have something to share on this, and maybe that was also some of the product of your presentation today. Perhaps we'll start with you, Dr. Kaiser, if you want to, and then over to Karine.
There are several projects going on, and I'm quite sure that I don't know about all of them, because it's also a bit going in my direction. I think the Swiss Corona stress study I mentioned, that will be continued. I think that's kind of really a big, well-done study with kind of this online questionnaire. We are doing some research ourselves, and we are mostly interested in two aspects: in the accessibility of mental health care. And so we're doing some work in collaboration with the psychiatric emergency unit. And we also want to see how kind of the hospital use and the outpatient use evolved during the pandemic, if the profile of patients changed. So what you would have hypothesized that during the pandemic peaks, the patients who actually came had really severe problems, because otherwise they would have stayed at home. So this is one issue, and these are also things that reflect what's happening in the general population. So there are really two levels, and there's this general population studies that are ongoing, and research on the mental health services that are ongoing. For example, the Swiss Association of Psychiatrists, they've done an online questionnaire for all psychiatrists in Switzerland to see how the practice had changed, and if they had more demand, less demand, and everything. But I didn't see the data until now, but this will also come out. So they're really on several levels. There's research ongoing in Switzerland and in Geneva as well.
Okay, great to know. Keep it up to date then. Karine, is there anything you wanted to add as well?
Yeah, maybe just to go exactly further to what just Professor Kaiser said. Actually, this is very important to continue the analysis upon the data, with all the data we could collect, because one of the biggest issue for university hospital is to be able to cope with crises, whatever they are, these medical crises. So that's very important, because it's really part of management, of a hospital, when you have to face such situations.
Great, thank you, Karine. We have a question that I'd like to pass to both Mary and Natalia. It's from Tina, and she's asking, we regularly hear from colleagues and family members that it becomes more and more difficult to cope with the pandemic. However, even despite getting advice for sick leave, they aren't able to go or don't want to go on sick leave because of workload. How can we kind of support this and address this, especially at UN Geneva? Over to you, perhaps, Mary, to start, and then over to Natalia.
Thank you, Natalie and Tina. That's a very good question. I think, yes, some staff actually come to see us when they've been struggling for a long time, and sometimes they feel it's almost like I give them permission to go on sick leave. They feel very committed, very dedicated to work, and they're aware that if they go on sick leave, then targets won't be reached, their colleagues will have to cover for them. So there's a lot of really good people, I think, that try very hard, and then with a bit of encouragement from us and from their doctors, we do say to people, just take a break, it's okay, and we're all part of a team. Nobody is on their own. And one thing with burnout, that's the only time I say, take a break for longer, but otherwise it's about working with us and your doctor, and then with your manager, because even when you return to work after sick leave, we can put things in place to help you. But yeah, there is sometimes shame or worry that you will run out of sick leave. But actually, I think UNOG has been very flexible, and even the sick leave without a prescription got increased. Maybe Natalia would like to add a bit about that. Or thanks.
Yes. We have repeated many times, and we had draw attention to the teams, to the managers, to pay attention and to be attentive to the signs and to the signs of fatigue in their staff, in their subordinates. And we also were promoting this staff well-being and trying to also de-dramatize, demystify, destigmatize this need to reprioritize. There will be periods in your life when the work will be important. There will be periods in life when the family will be important, and there will be periods in time when the health will be important. And we stress it, and we try to say to people to deculpabilize, I cannot say this, that they do not feel culpable not being able to come to the office and to deliver and to put burden on their colleagues. But we say that it is very important to come out of this, to reprioritize. Mary can help, the treating physician can help, the manager can help, and we invite people to use the entitlement to sick leave or to annual leave and to take pause in their lives. It contributes to their well-being. Everybody is understanding in the team and takes their flame, and continue their work. And we prefer to have healthy people and people who are doing well in their jobs rather than people who are burned out or who do not have energy to deliver.
Yeah, a good
Better
reminder.
to stop and to continue better later on.
Thanks a lot, Natalia, for the reminder, and Mary too. Thank you to all of our speakers. I'm afraid we're a little bit over time now, so hopefully we got to as many questions as possible, and sorry for the questions we couldn't answer right now, but we really hope that this session was useful for you. And there was a question about whether the slides are available. Yes, the correct answer is yes, so we'll make sure to share those slides with you. In fact, you'll see on the screen now how to access the slides if you'd really like them immediately. We have them on our research guide for this event, so Dr. Kaiser's slides are there. We'll also make sure to share this in the chat, the link here to the research guide for today. There you'll see the slides, but you'll also see a link to be able to search for relevant literature in the library. Also on the next page here, you can contact us if you want to join further sessions at the Commons. We send out a monthly newsletter, so you can subscribe. You can follow us on social media if you prefer to get information that way. And then also on the next page, we'll also be closing with the doors closing to the library as well as a survey to give us feedback on today's session. So thank you very much, Dr. Kaiser, Karine, Mary, and Natalia. But most of all, thanks to our attendees for coming and learning along with us. We hope to see you soon at the Commons. Take care, look after yourselves, and bye for now.